Thank you for having me and spending an hour of your life with me to learn a little bit about sleep. That's the next topic on our lecture series. For a heads up, for the next time we're going to be together, it's going to be urology. So spread the word. We'll be talking about all different types of incontinences and um, lifestyle changes and whatnot. So urology will be exciting next time. But for now, we're going to be talking about sleep. And it's, we have an hour together, and I usually stop 15 minutes before, so really 45 minutes, so that we have time for question and answer. And you could talk about sleep for way more than an hour because it's so critical. And it's interesting because you hear people talking about their hemoglobin A1C, their cholesterol levels. They'll talk about exercise, diet. They'll talk about mental health, all kinds of topics. But it's not common that you hear a conversation about sleep and the importance of sleep. And it's almost as if individuals feel that sleep deprivation is like younger college students and whatnot. It's almost as if it's expected. I was up all night studying for a test, or I was up all night if they're a resident dealing with medical issues of my patients, or it doesn't really put off saying, hey, this is actually not healthy, and it's quite dangerous. As a matter of fact, when I was in residency, there was a big case because one of the interns had sleep deprivation. They were up all night, and our call was either every 3 days. So it was either pre-call, post-call, or on-call. And so as you can imagine, after 36 hours, you're exhausted. And one of the residents, not in my hospital, but in a New York hospital, had given a medication that should have had questions before that medication was given. It was an MAO inhibitor, and they should have asked a certain number of questions before administering that. They administered it, and it unfortunately had a poor outcome. But that's the bad news. The good news is it really brought to light that sleep deprivation can have devastating consequences. And as a result of that, there's limitations on hours that a medical resident can work, and they've instituted night float system and caps on the number of patients you can have. So it ended up in the long run being beneficial for future, hi Larry, welcome, for future medical staff. And it continues to be something that we need to talk about, not just when we have a devastating consequence, but it should be part of a routine physical. So when a patient comes in, you should, anyone, whether it's a nurse practitioner, a PA, an MD, should always ask, how is your sleep? And the reason being is there's a cascade of consequences that can result as a result of insomnia. So when someone comes in and they say, I have problems sleeping, can I have a sleeping pill? That's what they want. They walk in, they say, I can't sleep at night, I want a sleeping pill. And I'm not going to pull out a prescription pad and write for a sleeping pill, because that's not fair to that person. So the way I address and approach my patients is the way I want to share with everyone here for this time together is, when you have insomnia or difficulty sleeping or lack of sleep or lack of quantity of sleep. It has to be clearly defined. The same way if you say, I have dementia, well, what does that mean? Do you have Alzheimer's? Do you have frontal temporal? Do you have Lewy body? Do you have Parkinson's disease dementia? What type of dementia do you have? Vascular? There's so many different types. So when someone comes to me and says, I need a sleeping pill to sleep, it's just too broad of a category. It has to really be broken down. So I want to learn, are you having a difficult time falling asleep? Are you having a difficult time staying asleep? Are you waking up early, like 4 o'clock in the morning, and you can't go back to sleep? So, and we're going to break it down into those three questions because it's very, very important. So if you have a difficult time falling to sleep, my question is always, why? Is it that you had a late dinner and had caffeinated products, whether it's soda or coffee or tea with caffeine after your meal? You know, what did you consume that was stimulating? What did you not only drink, but what did you eat? Did you have chocolate? Did you have, you know, what exactly was your pattern before you went to sleep? And also, not only what's going to keep you awake, but I want to know if you're eating that late, what are the consequences of that? So a lot of individuals who eat very late, they'll have gastroesophageal reflux where the food has not gone down and they feel acid in their throat and perhaps they're coughing and perhaps they have chest pain, all as a result of not having the food where it's supposed to be digested properly. So there's a lot of things that have to be asked as to the consequences of your whole sleep hygiene. So the easiest thing to do is to say, walk me through your day. That's the easiest thing. Because if I say, if you have a hard time falling asleep, staying asleep, or waking up, that is an answer. That's true. And that helps me go down a certain path of questioning. But it's even more important to understand what the day, a day in the life of this patient is. So I say, what time do you wake up? Let's start off with that. And they'll say, I'm just making it up. They'll say, I wake up at 4 o'clock because I can't sleep anymore. And then as I'm understanding their whole course of the day, I find out that at 2 o'clock, they're taking a nap from 2 to 5. And then they wake up and they make dinner. Well, that's an easy intervention. And so what I say is if you're napping for several hours during the day, you very well may have a hard time falling asleep. Or if you're changing your sleep-wake cycle where your body feels fully rested and it knows it's going to be refreshed in the afternoon, then we have to break that cycle. So that's one, one concern is what time are you awakening and why? A lot of people do wake up very late. So they'll wake up 10 o'clock, 10:30, and then they can't fall asleep until 1 o'clock in the morning. Same exact thing. You're just moving your sleep-wake cycle, and it has to be reversed. It can get so bad that some people are up all night and sleep all day. And so that absolutely has to be broken. And it could be very difficult because what we have to do is we have to keep that person up as long as we can during the day so that when it's an appropriate time to fall asleep, and appropriate is very subjective, but let's say 10 o'clock, we'll put that as a number to fall asleep. They're going to be so exhausted that they're going to crash, and they're not going to wake up in the middle of the night because they're so tired.
Susan,
And
I
that,
have heard that it's better to wake up without the alarm. Do you think that's true, and is that important or not?
yeah, I do. I think that's absolutely true. I think that your internal body will tell you when it's fully rested and when it should get up. Um, Obviously, if you have a job and you have to be at work, so for example, for me, this entire week, I had 7 o'clock patients, and I'm an hour away from work. So I have to be up at 5 so that I can leave here by 5:45 so that I can drive the hour and get to work. So I can't rely on my internal clock to make sure that I get to work in time. But absolutely, Larry, that's very true. Uh, Having your internal clock wake you up is a healthier way to do it. And that's your body's way of saying it's ready to go.
Thank you.
You're welcome. So um, learning through their day. So they wake up, let's say they wake up late and they go to sleep late. That's an easy fix. Let's say they eating late and they're having that gastroesophageal reflux, which is causing them discomfort during the night, causing them to go have a snack. And sometimes people feel that their solution to this reflux is eating or drinking milk or something to coat that discomfort, or maybe they'll take a Pepsid or Pepsid Complete or some other over-the-counter medication. But the point is, they're disrupting their sleep doing all this. So the recommendation is to have your last meal by 6 o'clock, not by 9 o'clock. And it gives your food enough time to get out of the stomach, get properly digested, you're sitting upright, and that will decrease any kind of nighttime complications. And then, just kind of listening to them again, as far as their day, what are they drinking? Are they drinking at the end of the night a whole bunch of water? And then when you learn of the diary of what they're doing during the night, they're voiding, well, it's fair to say decrease your fluid intake as you're approaching the time to go to sleep. Now, I always recommend by the bedside to have a little 4-ounce bottle of or glass of water, simply because when you're laying flat in bed, just that physical flat position is creates a diuresis. So it's a diuretic effect, and the fluid goes into the kidneys, and that's why your bladder fills and you void. So in the morning, you certainly can be dehydrated. And if you are dehydrated enough, when you're getting from laying down to sitting up, you could get woozy. And when you're going from sitting up on the side of the bed to standing, you can certainly have an orthostatic hypotension, and you don't want to faint. You don't want to have a fall and then break your hip or hit your head or so on. So you absolutely want to have water by the side of the bed, so that this way, if you do feel lightheaded, you drink. A lot of people say, well, the reason why I'm rushing out of the bed is because I have to void and I don't want to be incontinent. I don't want to void all over my bed. So if that's the case, and as I said, next time we're together, we're going to talk about urology, but if that's the case for the men, I recommend having your urinal by the bedside, and for the women, a commode by the bedside. And ultimately, if it's a choice between you losing some urine and having to change linens or your pajamas versus you fainting and falling and breaking something, I would recommend losing a little bit of urine if you can't get to the bathroom in time, if that's your concern. So anyway, so you really need to do a voiding diary and say, when did I last drink and what times am I waking up at night? So that you can really understand whether it's you creating this voiding frequency or if it's another condition such as nocturia. And we're going to talk a little bit more about that and what that actually means, because there's conditions where your body makes more urine. But let's just talk about the normal. The normal is you're consuming it and you're going to have to void it. So you have to time it out and say, when is this happening? And then the most obvious, reviewing medications. What medications are you taking and when? And you really want to know what are the component parts of your medications. So there are medications in which you can have a diuretic combined with another medication, or these combination pills are sometimes you don't know what's in them. So what you want to know is, what pills am I taking? What are the indications for these pills? And then what are the, not only the mechanism of action, but what are the side effects? So, simple, straightforward Lasix, straightforward just as it is it's a diuretic, obviously, and it's going to drag water out. So when are you taking this? Now, a lot of older adults don't like to take a handful of medications 8 o'clock in the morning. They like to spread them out because they feel it's just too much medications, and some people complain that it's hurting their stomach, and so they make a decision that they're going to spread it out during the day. And their doctor doesn't know that. So if you are going to take that initiative and spread out your meds during the day, know which meds you're spreading out. So if you're going to take, for example, a Lasix, you want to take it in the morning so that you have the 6 hours of diuresis versus taking it at nighttime and then you're voiding the entire night. So understand your medications, understand the dosing. And if your prescriber does prescribe it at nighttime, review with them and say, was this intentional? Was this a mistake? You could certainly go to your local pharmacist and have a consultation to review your medications and say, this is what I'm experiencing, or any of these medications causing my urinary frequency at night. So once you're getting the whole kind of idea of the day, walking along with that person for the day, you really get an idea of whether it's medications, whether it's fluid, whether it's sleep patterns. And then you want to say, okay, so now you went to bed. What is going on? So a lot of people tend to watch TV in bed, or if they wake up in the middle of the night, they'll read a book, or they'll open up TV in the middle of the night and wait until they fall asleep. And the recommendation is that for those who have insomnia, now for those who don't have insomnia, it's a whole different conversation. You could do anything you want. But those who are complaining that they're having sleep problems, the bed should be exclusively for sleep. So this way your mind associates the bed with restful night's sleep. If you do wake up in the middle of the night and have to go to the bathroom, or you don't know why you wake up and you go to the kitchen and you eat, and then you come back and grab your book or look at your cell phone or look at your iPad, those are all habits that have to be broken for the person who has difficulty sleeping. So for the person who has difficulty sleeping, if you wake up and you can't go back to sleep, you should not be looking at the clock every 5 minutes and saying, oh, it's 2, it's 2:05, it's 2:10. No, you should remove yourself from the bedroom, go out into the living room. If you want to read a book there, that's totally fine. But once you're tired, leave the book in the living room, come back to the bed, and you should try to fall asleep. Once again, having your mind associate the bed only with sleeping so that it doesn't get confused and saying, ah, this is stimulating. Now, some studies recommend that 1 hour before you go to sleep, you should kind of turn your mind off. What does that mean? Don't watch the news. Don't watch sports that you find fascinating, interesting, frustrating, or political channels, or anything that would cause your mind to think. So the recommendation is an hour before you sleep, you should be doing mindless activities. And mindless activities are, for example, pressing your clothes, or picking out your clothes for the following day, which is not really, some people put a lot of effort into it, but others just make sure that they have the necessary pants, socks, underwears, and so on and so forth. Okay. So basic stuff, but not anything that would cause a tremendous amount of synapses in your brain. Because the idea is to tone down that activity. You don't want your brain constantly stimulated. You don't want to read an interesting article in which your mind says, what does that mean? What did the author mean? Or what does that mean for my finances? Or what does that mean for my health? Or what should I do? What should I not do? You don't want anything that would cause curiosity. You just want your mind to rest. Some people, some studies have recommended soothing music, which just calms you down. Now, when I was at Yale, for example, the Elder Horizons program in which I ran, we had a non-pharmacological sleep protocol in which we would have volunteers go in and they would give a back rub to soothe those muscles, not a deep muscle massage, but a back rub. And that really soothed the patient. They would make sure that they had the enough blankets so that they weren't cold. We didn't want them sweating, but they wanted to make sure that the temperature was comfortable. And they put relaxing music on, in addition to a warm chamomile tea, a beverage of choice, of course, non-caffeinated. So with the back rub, the warm drink, the chamomile tea, the blankets to adjust the temperature, and the soothing music, we were able to decrease sedative hypnotics dramatically. And so we instituted on all patients non-pharmacological sleep protocol and had a better quality of sleep. So that's absolutely very, very important. So when we're going back to those 3 questions, are you having a hard time falling asleep, staying asleep, or waking up early? Why do we ask that? Well, if you're having a hard time falling asleep, is it because you woke up very late? You woke up at noon and now you're 8 o'clock in bed and your body's not exhausted enough, so you can't fall asleep. Is it because you had caffeinated items? Is it because the acid reflux is really bothering you? Is it because your mind is racing and your mind is thinking, I have to do this, I have to do that, I have to do the other thing. Oh my gosh, I can't do this now because it's closed. And what am I going to do? And how am I going to do this? So is your mind racing? If your mind is racing, then you need to get out of bed. You need to get a pen and paper, and you need to write all the items that are weighing you down. So if you have to buy a birthday card, if you have to pay a bill, if you have to go to the doctor, Whatever is racing through your mind, write it down. And then you have to convince yourself and say, okay, this is obviously causing me a problem. So tomorrow I am going to at least address one of these items on that list. And when tomorrow comes, you have to address one of those items on the list, because your brain is very smart. And if you write this list and you say, okay, I'm going to address it, and then the following day comes and you don't address it, your brain is not going to believe you. So you can write all the lists in the world and your brain will never let you calm down and turn off so that you can fall asleep. But if you show to your brain, okay, I have a list of items that I need to address, and the following day you actually address them, your brain gets a positive feedback and says, they said they were going to do it, they did it, so let me rest. Okay, that same approach applies in the middle of the night. So if you wake up in the middle of the night in a cold sweat, oh my gosh, I was supposed to do this, I was supposed to do that, this is due, that's due, and I didn't call this one, and oh no, I'm going to get in trouble with this, I hope I don't lose my job with that, oh no, I was supposed to pay that bill, and leave the bed, go to the kitchen, write down your list, tell your brain, I'm going to table it, there's nothing I can do at 2 o'clock in the morning. I'm going to table it, and tomorrow I will at least attack one item or the most critical items on this list. You do that, you will fall back to sleep. It's not going to happen the first night. It probably will happen after 3 or 4 times, because you have to prove to your brain that you're speaking the truth. Okay. So once again, you're having a hard time falling asleep. That's important. A lot of people say, as I said earlier, can I have a sedative hypnotic? Can I have Ambien? And I say, well, it's important to know what we're treating. So if you're the type of person who you going in bed and you have a racing mind and you do this list situation, that's one person. The other person is you just have anxiety. You're just extremely nervous and overwhelmed, whether it's the pandemic, whether it's the loss of a loved one, whether it's your finances, whether it's your physical health changing, deteriorating, whether it's the fear of the unknown. But during the day, with the cars going by, the birds singing, people calling, you having to eat or having to go do chores, that's a distractor. But when you're laying in bed and it's just you and your mind, that's really frightening. So I say, if I give you a sedative hypnotic, when your insomnia, your difficulty, having a difficult time falling asleep is anxiety, and let's just say you fulfill all the criteria for anxiety, then I'm doing you a disservice, because the reality is a sedative hypnotic will put you to sleep temporarily, but you never treated the underlying anxiety. So the goal is to treat that anxiety. Now you can treat it through non-pharmacological approaches, yoga, deep breathing, meditation, or you can give an anti-anxiety medication. And if you give somebody who has anxiety, not allowing them to sleep, an anti-anxiety medication and or non-pharmacological techniques, that person will fall asleep and will have to continue to learn coping ways of dealing with this anxiety. Okay, so that's important. It's important to understand why they can't sleep. Is the person who's having a difficult time falling asleep because they're in pain? When they lay down, they have sciatic pain, or they have let's just say peripheral neuropathy pain or cancer pain? Or is it that, once again, in your bed, there's nothing to distract you? So everything is under the microscope, whether it's your mind or whether it's your physical body in your pain. So all you can focus on now is that neuropathic pain, that sharp shooting pain, that needles and pin pain, or a dull achy pain, whatever the pain is. So once again, is it fair to give somebody who is saying they have a hard time sleeping a sedative and hypnotic when they're in pain? No, it's not. The right thing to do is to address the root cause of the problem, whether it's pain, whether it's anxiety. What is the root cause of the problem? And that is the medication of choice, or the techniques, non-pharmacological techniques to approach that and resolve that. Okay. So that's the person who's having a hard time falling asleep. The person who has a hard time staying asleep, well, that is the majority of the people. They fall asleep and they wake up. Why are you falling asleep and waking up? Are you waking up to void? If you're waking up to void, I want to look at your voiding diary. I want to see how much you drank before you went to bed. If you tell me that you did not drink before you went to bed, and you are voiding more than 2 times at night, then that's definitely something that needs to be addressed medically, because your body can certainly be making more urine than at nighttime than it's supposed to, and that's a medical condition. Okay. Then I want to know, are you waking up early morning awakening and you can't go back to bed? A lot of individuals who have depression will fall asleep, but they'll wake up early and they can't go back to sleep. They're just turning and twisting and turning and twisting. And so I will ask about sleep disturbance in general for those who have depression. And as I said, there are at least from my experience, individuals who wake up early have the depression. Now, depression can be hypersomnia. You sleep too much and you're trying to escape the world you're living in because you hate it so much. So they're sleeping all the time. Or insomnia, you can't really sleep because what you hate so much and what's causing you depression is consuming you so much that you can't turn it off. So it could definitely go both ways. So sleep disturbance in general is a question that we have to ask when we're talking to someone who's depressed. Then who are you sleeping with? Are you alone? Are you sleeping with a dog that is pushing you and kicking you, and or the dog is snoring? Are you sleeping with a bed partner who is snoring, and perhaps that bed partner has sleep apnea? Perhaps that bed partner is sleeping really loud and then stops breathing, and then you hear the gargling and so on. And it's so disruptive to you that you have to push your bed partner and say, roll over. Can you stop with the snoring? And that person is sleeping, you're awake, and you're the one who's trying to change that person's position so that they could fall asleep so you can go back to sleep. So that's another reason for disruptive sleep. Are you with a bed partner that has restless leg syndrome, in which your bed partner is constantly moving their legs, and you are being woken up because they're constantly moving and constantly moving? Okay. There's also a REM sleep disorder, in which has to be addressed. And of course, acting out on your dreams, which is very dangerous. You can have husband and wife come in, and the wife has a big black and blue, and the husband punched her in bed, and he has no idea that he did that because he acted out his dreams. So there's medical conditions that can be corrected. So sleep apnea, absolutely. We have really advanced tremendously with CPAP machines, and they're much more quiet, they fit better. really we advanced so that we can get the sleep apnea under control. And you want to get it under control because there's a lot of poor consequences as a result of the hypoxic episodes. Because, I mean, it's called sleep apnea because you're not breathing, you're apneic. And when you go for a sleep study, they'll tell you how many apneic episodes you've had. So think about it. Your brain is going without oxygen at whatever frequency, and that's how they can adjust your CPAP, or if you need a BiPAP, and BiPAP has an inspiratory and an expiratory rate. So, and you've heard a lot about BiPAP during the pandemic because they use that instead of ventilators when we were in a shortage. So that can certainly be addressed. And so you do want to understand what's happening during the night that's causing you not to be able to have a full night's sleep. Now, why is it important? And I took some notes so that I wouldn't forget to tell you the details of why it's so important to have a good night's sleep. So a lot of individuals will come to me and explain that they are experiencing cognitive deficits, and they're afraid. They're afraid because they did get into a car accident. They are older, and they're just afraid that they're going to get their license pulled or they're going to lose their job. So they have me evaluate them for dementia. And after doing all my testing, I find out that they don't have dementia, any of the dementias. They have a pseudo dementia due to sleep deprivation. So I wrote a list of items, and Larry, I have that list, and I can certainly send it to you so you don't have to write it down. But it's the burden of basically not sleeping, and what are the consequences that I've seen in my practice, and you've probably seen amongst your peers or even yourself. So studies have shown that, and in my practice has shown that not sleeping absolutely reduces quality of life. And we do quality of life questionnaires, and it absolutely interferes with one's quality of life. And this doesn't mean that you have to be geriatric. You can be an 18-year-old and with sleep deprivation have a decreased quality of life. Poor overall health, and we're going to go into reasons why. Reduced work productivity. The reason why you have reduced work productivity is perhaps you overslept and you go in late. When you're in work, your mind has a cloud. You don't feel crystal clear. Okay? Absolutely poor mental health. Increased fractures and falls because you're not as crisp as you used to be because, once again, you're sleep deprived. Increased mortality, and I have a reference for that if anyone's interested. But yes, increased mortality and increased frailty. And people don't really associate sleep deprivation with mortality and frailty, but it definitely is. So those are the associations. The short-term consequences and long-term consequences. Let's talk about short-term consequences. Short-term consequences of not sleeping: increased daytime sleepiness. So you're dozing off. If you're at a senior center, if you're at assisted living, if you're in an assisted living and you're at a lecture, or if you're at bingo, or you're going to have increased sleepiness, and people are not, they're going to wonder why you're always sleeping, essentially. Reduced daytime energy. So you're not as robust as if you had a higher quality sleep. So you just feel like you're dragging, because anybody who's sleep deprived is absolutely dragging. We need sleep for survival. Longer reaction time. So when the person comes to me and says, I have dementia, help me out, and I'm asking them questions on the mini mental. And by the way, we are going to be doing on May 14th memory screens and what that means. I'm going to go through what a mini mental is. So they'll just stare at me. So I'll say, something like, can you spell world backwards? And they'll just stare at me and really have to think about it. And they're just slower. They're slower in retrieving that and reacting to anything that I'm saying. The problem with longer reaction time is you have reduced psychomotor performance. So if you're sleep deprived and you're at a red light and it goes red to green, you're not as fast to respond. Or if someone honks, you're not as fast to respond. And so you can easily get into accidents that way, or you could fall asleep at the wheel and get accidents that way. Especially if it's snowing or raining, it's almost mesmerizing. So if you're sleep deprived and it's snowing and the snow is hitting an angle at your windshield, we've seen, unfortunately, many accidents during that time, not because they spun out, but because the snow or the rain was so soothing and they were so sleep deprived that it just put them right into a deep sleep. Decreased concentration, memory, and cognitive function, that I see extraordinarily commonly with people saying that they have dementia when they don't. They do have decreased concentration. They do have decreased memory, but it's not because of neurofibrillary tangles and plaques. It's because they're sleep deprived. And then for the short-term consequence, poor mood. We make fun of children and say, go take a nap because you're overtired. And we don't think of adults because adults we just expect are going to be sleep deprived, and that's just the way it is. But it's not. It has consequences. And so that person will be agitated, have a short temper, or may have a different personality trait than we usually know. Long-term consequences, and now this is important. Long-term consequences of sleep deprivation can cause depression. Now look at that. I said I'm going to ask them if they have depression that's causing them to sleep too much or too little. And now I'm saying if you're not sleeping and you don't have depression, it could cause depression. Okay. And as I had mentioned on one of our other lectures together, depression, when we evaluate people who have Alzheimer's disease and we look at their history, those who have clinical depression have a higher incidence of fast forwarding, let's say 10 years in the future, of having a diagnosis of Alzheimer's disease. So imagine that. Because you're not sleeping, you get depressed. Because you have depression, you can get Alzheimer's disease or have an association, a higher association of getting Alzheimer's disease. So that's all very, very important and critical and is preventable. So long-term consequences: increased susceptibility to somatic disease, risk of cardiovascular disease, risk of car accidents, as we mentioned, risks of falls and fractures. Why? Because you're not really paying attention. You're not really looking where your feet are in place. You're just so almost like having almost like a hangover either due to medications or hangover due to alcohol or hangover due to sleep deprivation. And of course, long-term risks is mortality. So before we turn it to any kind of questions, I do want to say that the sleep cycle is extraordinarily important. And waking up during the first 3 to 4 hours of sleep is most likely to lead to fatigue, increased discomfort, and decreased pain threshold. So when someone comes to me and says, my lower back pain is worsening and worsening and worsening, I often say, how did you sleep? And they're saying, are you saying that my bed needs to be changed? Do I have to get a harder bed? And I say, no, I'm not saying that it's your bed that's causing your back pain. I'm saying that if you're not sleeping well, that can cause decreased pain threshold. And so your perception of the pain is such that you're coming to me complaining, asking for a higher dose of medications to treat it. And so imagine that if we can sleep better, we can decrease our pain meds. And then, as I said earlier, but I want to reinforce now, patients with greater than or equal to 2 voids per night, experiencing an average of 2 to 3 hours of sleep before waking up to void. So if you're voiding greater than 2 or more voids per night, that's not normal, and that has to be evaluated. And as a result of that frequency, you're probably waking up between 2 and 3 hours, which is right in the time that you're supposed to be sleeping. So you should have 3 to 4 hours of your first falling asleep. Once your head hits the pillow, you should sleep 3 to 4 hours to have restorative sleep. If you don't, because you have to get up to go to the bathroom, then you've disrupted that restorative sleep, and the following day, it's going to be a problem. And a lot of people say, well, Dr. Varano, I went to sleep and I was in bed 10 hours, so I should have been rested. And I say, you could be in bed 24 hours. If you don't have that restorative sleep, then you're not getting sleep at all. So that's important to know. So I think I have some other stuff, but I do think that it's important to kind of spend the rest of the time asking and answering any kind of questions in relation to sleep. So I think I'm done with the key points. Any questions? Larry, I don't know. I know you had a question before. I don't know if you have any other questions or any questions that you think others who are not on the call might have that I should answer.
I don't have any more off the top of my head.
Okay. All right. So yeah, I think those are the big points. There is, let's see, I want to pull it up for you.
Oh, Susan, are there any sleep medications that you would recommend?
So I'm a big fan of non-pharmacologic because I don't want people to feel that they're going to take this medication or that medication and that will cure the problem. Because as I said, if your inability to sleep is anxiety, then I want to work on that. Or if it's pain, I want to work on that. If it's your partner's sleep apnea, I want to work on that. So I very rarely use sleep medication. I know, I think on our second lecture, I think when we were talking about cognition and depression and dementia, someone had asked how I feel about melatonin. And I had answered then, and I'll answer that now because that is a common question. I don't have a problem with melatonin. If an individual wants to take it, they certainly can. The only recommendation I would have is you've ruled out everything else. So you've ruled out anxiety, you've ruled out depression, you've ruled out pain, you've ruled out a busy mind, an active mind. You've ruled out stimulants such as caffeine and foods and whatnot. You ruled out medical conditions. So once everything else is ruled out, then yeah, you certainly can try melatonin and see if that helps.
Thanks, you too. Bye. Yeah.
So
My candle.
are there any other questions that I can answer or you think anyone else has? If not, I think we're in good shape. You're muted.
Oh, I was just gonna say, if nobody else has any questions, I was just gonna say it was interesting to listen to because some of that information applied to my life. So I'm kind of glad I listened in.
Okay, great. And you know, if there's one key point that I want to bring home, it's for those who have difficulty sleeping, don't don't use the bed as anything else other than a place to sleep, and your mind will associate that. And also for those who have difficulty sleeping, truly try. It's gonna take a couple times, maybe 3 times, maybe 5 times. So that means either 3 or 5 days or maybe a week. But try to turn off your mind an hour before you go to sleep and try to soothe it. And then when you wake up in the morning, try to avoid grabbing your phone and reading the news and jolting your mind, because that just starts your day with anxiety. So if you can, an hour before you go to sleep, shut your mind down, and an hour when you wake up, slowly introduce stimulus to your mind, you're going to have a much even day, less anxiety, and greater quality. So that's something that takes practice. It's we're all attached to our smartphones and TVs, and we're all constantly revved up, and that's just not healthy. So if we could try to break that, you'll see a tremendous improvement in your quality of life. And I think that's my last point.
This is Jody. I'd like to ask a question.
Sure, Jody.
I have terrible time staying asleep for more than probably 2.5 hours, maybe 3 hours. I've tried melatonin, extended release, and it's, I don't know, helped a little. My doctor has offered to write a prescription for trazodone, but I've declined that so far, but just wondered if you had an opinion on trazodone.
Well, we do. We definitely use it, and it definitely works. But before you jump into that, why don't you do some self-reflection and think about what we talked about today, and see if anything that I mentioned could be a contributing factor to your difficulty staying asleep. And if it is, then, as I always say, go to the root cause of the problem and try to fix that. So this way you have the proper medication for the proper problem, or the non-pharmacological treatment for the distractor or what's causing you to not sleep properly.
Okay, thank you. I recently read that jasmine oil kind of helps. I've been trying that in my diffuser at night, and it's been about a week. I think a few nights I got a little bit better sleep on that. I don't know if it was that or something else.
Well, yeah, I mean, jasmine is definitely, I've heard success with that. Of course, lavender, I've heard success with that. There's a lot of different companies. There's a company called Melaleuca that has roll-ons that are sleepy time roll-ons, which are a combination of a lot of different natural, similar to the lavender and so on and so forth, but it's a combination, and it's supposed to help with sleep. And they recommend putting it on your temples, on your feet, on your wrists, and a lot of patients have said that has helped. So I think, honestly, anything that can turn down we're so in the United States, we're so revved up. We really are. We wake up, we're running. We go to sleep, we're constantly thinking about the following day. We have a really hard time of living in the moment, and it's just the way it is. So if we can break that and truly live in the moment and try to settle down our mind and let it come to peace and rest, it really does work. It really, really does work.
Okay. Could you repeat the name of that company with the roll-on?
Oh, it's called Melaleuca, and they have, if you just go into Melaleuca and you do essential oils, they'll have a whole host. They of course have jasmine, lavender. They have, as I said, a combination for roll-ons to fall asleep. They have a whole host of things. And, you could see if there's anything that works for you. Just to let you know, for the Melaleuca though, it's like a Costco where you have to kind of pay a membership. So you might want to look into that, but you don't have to get it from them. You can get it, you can look around and see what works for you. But I just want you to know that essential oils have definitely helped a lot of people. And so if you feel it's helped you a little bit, definitely pursue it and see what else could help you.
Thank you.
Welcome.
Dr. Varano, this is Diana. I have a question for you regarding getting up in the night to go to the restroom. I usually do that maybe 2 or 3 times during the night. And I did bring this up with my primary care doctor, and she said, well, do you have to go frequently during the day? And I said, not that I'm really aware of. And she said, well, just stop drinking at a certain time before you go to bed. So what would you say about that? As far as how far ahead of time should you stop drinking?
So, so a couple of things you just said to me that kind of brought some synapses firing in my brain. So if you are not voiding frequently during the day, but you are voiding frequently during the night, then I would recommend seeing you could talk to your PCP about it, or you could talk to your urologist about it, because it sounds like you have nocturia or nocturnal polyuria. And what happens is individuals who have nocturnal polyuria, they have a reduction in what's called AVP, and it results in dysregulation of water absorption and increased urine production. And your restriction of water prior to going to sleep, it won't really work if you do have this dysregulation, because your body is going to produce more water, and you could end up getting more dehydrated when you wake up. So the way we diagnose this is basically a 24-hour urine. And what you want to do is you want to look at the urine during the day. What's the volume? What's the urine during the night? And there truly is a formula that we use to determine whether you have a disproportionate amount of urination at nighttime versus daytime. And if it is, it's pathological and has to be at least diagnosed and treated. I mean, there's not that many drugs to treat it, but it's very important to know what you're dealing with and look at the options that are out there for you. So my recommendation would be you could bring that up with your PCP, or you can just go to a urologist if your insurance allows it, and say, I did a 24-hour urine. This is how much I void during the day. This is how much I void during the night, or the frequency. And you could get a hat, like your physician can give you what's called a hat, which is just a plastic, it looks like a hat that's upside down, and you put it in a toilet, and you can do volumes, or you could just do frequency, and then present the data and say, is there something going on that's pathological that I need to address? And that's important, just to have a proper diagnosis.
Thank you.
You're welcome. Any other questions or concerns? Okay, so